Good afternoon, everyone. I'm Jeff Buchhalter, and I was asked to talk about guidelines from the perspective of how professional organizations develop them. Of course, guidelines are fairly dry, and so I wanted to expand the topic a bit to include quality measures and clinical decision support, because what we're all interested in is how all that stuff relates to action. And so that's how the topic sort of evolved. The disclosures are really just to say that the American Academy of Neurology, the Child Neurology Foundation, and the Child Neurology Society are deeply committed to neurologic disorders in general and rare diseases in specific, and I've had the honor of working with those organizations in a variety of capacities. So, a couple of topics. Why do we need guidelines? What is a guideline? How are guidelines developed? And I'll use the American Academy of Neurology model. What are the limitations of guidelines? How do quality measures figure in? And then how do you bring guidelines and quality measures into practice? So what are our goals, our universal goals, I guess? And pretty straightforward. Every person with a medical condition, rare or common, we don't want to discriminate, receive care that leads to optimal outcomes and quality of life. It's essential that the people involved, patients, caregivers, share in the decision making as to what and how care is selected and delivered. It's essential that the decision is made based on best available evidence. And it comes down to how well does it work and what are the adverse effects of any particular treatment. And finally, the issue of societal resources. We can't exist in a bubble thinking things don't cost something. And we can talk a little later, but I'd like to forward the idea that by being cognizant of resources, we can use that as a lever to promote diagnosis and treatment of rare and common diseases. So what are the challenges that we have? Well, first of all, for many conditions, we don't know what that is. The second big point that I put in bold so I wouldn't forget to emphasize it is that there's a tremendous body of available evidence on which to base care, but it's so big that it's beyond the ability of any individual to synthesize it and know it all and bringing it to the care interaction. When I had hair, it was easy. We didn't know that much. Time has passed. The genetic revolution, for example, can't keep it in your head. Access is limited. This is a societal problem which I'm not going to address, and resources are limited. So why are guidelines necessary? Well, there is evidence that via guidelines, standardized practices lead to better outcomes. And for me, and I think for us, that's the bottom line, outcomes. There is that large body of evidence that I referred to previously, and no one can know it all and bring it to the patient care interaction. Finally, standardized practices allow interventions to be evaluated. Because if we're all doing something differently and someone is successful with an intervention, how does it apply over here? It allows us to practice as a community. What is a clinical practice guideline? Well, the statement from really is the NIH. Clinical practice guidelines are statements that include recommendations intended to combine patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care approaches. That's a clinical practice guideline. Prior to that, there was a whole literature developing how you develop a clinical practice guideline. So this is a formal statement of what one of these things is, a recommendation. Now, This is the 2017 American Academy of Neurology Clinical Practice Guideline Process Manual. It's about an 85 single-spaced document to say how you develop a clinical practice guideline. It's a big deal. And for those of you that are taking pictures, I will make all my slides available, so not to worry. I've put the process on wherever it says figure 1, your right or left. Evidence-based medicine. You ask a question, you gather the evidence, you come to a conclusion, and you make a recommendation. That's what all the pieces are. It is a complicated process. In the middle, well, I'm using a pointer here that you can't see. In the middle is a flow diagram of a typical guideline development. Started with 769 relevant articles discovered in the literature. In the end, after going through all the criteria that one uses, there were 32. To go from 769 to 32 is a big deal. On your right, where it says forming the development panel, what is the group of people that comes together to create a guideline? It's usually between 5 and 10 individuals, at least one current or former patient, and I'm emphasizing patients throughout the presentation. And at a minimum, patient involvement should include participation in clinical question formulation and review of the draft guideline. Need to be involved. On your right are all the steps that the Academy goes through to come to a guideline. I was involved with one that started in 2007. It was published in 2017. It was painful, but it was very good. So it's very, very complicated. The American Academy of Neurology has a bunch of guidelines, and I've just listed them here. Each arrow lists, the specific guidelines in every category. And just to say that a lot of genetic disorders are embedded in the guidelines. Now, say that's great. We have this knowledgeable, evidence-based review of guidelines which are recommendations for practice. What's the problem? First of all, they're very expensive to develop. Everyone wants a guideline, and it costs tens of thousands of dollars to do one, so it costs. A more fundamental problem in my book is that these are suggestions without measurement or accountability. How do you know if you did it, and who knows about it? That's not in a guideline. Let's say you have a guideline with 50 steps. How do you incorporate that into the office workflow? Because that's where you really want it. And clinical practice guidelines are not followed. This was a sort of an aha moment for me a number of years ago when I started reading this literature. You have the guidelines, but the people that should be doing it aren't doing it. On your right, I guess, is this list of reasons for noncompliance. Folks say they're too complex, multiple rules in a single guideline, disagreement, a whole bunch of reasons not to do it. But that invited article, there's a fundamental reason. As my daughter said to me when I asked her to do something when she was 3 years old, "You're not the boss of me." She's now 30, and I'm still not the boss of her. Physicians don't like being told what to do, and I don't know how to sugarcoat it because we work hard, we try hard, we have the best interests of our patients, in our hearts. But hearing how to do something from people we don't know can be difficult to swallow. So there's that autonomy issue that we just have to get over it. But I wanted to put it out there. Now, as Tina Turner said, gotcha, huh? What does love have to do with it? What does value have to do with this? It is as follows. As many of you know, the expenditure for healthcare in the United States runs about 18% of the GDP, outstripping by 3 or 4 times other modern countries. And when we look at our outcomes, they're no better, and in many cases, far worse than people spending a half or a third or a fourth. At some point, the government said, you know, you can't just bill for what you're doing. You have to demonstrate value. Have to. It's written into law. So the value equation is the quality plus the service you're delivering divided by the cost. And that's how things are being measured as we go forward. And personally, I think it's high time. Now, quality. What's quality? Quality is determined by outcomes which must be measured. These outcomes are quantified by quality measures. So that is the accountability, and they're based in guidelines, the evidence. So that's the connection between guidelines and quality measures. One is derived from the other, but quality measures are quantifiable. Again, the academy and other academies do similar things. Development of a quality measure. And what you see is it looks a lot like the development of guidelines process. The review of the literature. Components of a quality measure determine who you're talking about, the population. Then you have to have a numerator who meet the criteria, and a denominator, all the people that it's applicable to. So, infantile spasms, a rare epilepsy. The guideline which we produced, quality of patient care, number of patients who meet criterion versus eligible populations minus exclusions. And so then you get a number. And the purpose was to ensure the rapid and appropriate treatment of infantile spasms. So people get a certain level of care, whoever they see. Work group. Who's the work group for quality measures? 2 to 3 patients or caregiver representatives. And so this is a movement that's growing to have the people that are affected by a particular quality measure at the table. And the Academy has done a wonderful job of that. The 3 R's of quality measure use. I made this up, so don't take it to heart. What are quality measures used for? First of all, it's a new reimbursement scheme. You got to show quality or you don't get paid. That's fairly powerful. Resources. If your institution wants to get paid, they need to produce the resources you need to deliver quality care. And finally, you can brag as a center of excellence if you're meeting quality measures. So the QMs have a whole variety of purposes. So now you have guidelines and quality measures. How do you operationalize them? I didn't know about operations till about 10 years ago. I just thought if we just thought something, it would happen by magic. It doesn't work that way. And so how do we all interact to produce quality? One lead into this is via the Rare Epilepsy Network. So I'm a pediatric epileptologist. That's what I've done all my professional life. And REN is an organization, and you can't see it, but right below it lists all the groups that are part of it. These are predominantly genetic epilepsies. And just to say it, we don't know the cause, so-called idiopathic epilepsies, unknowns. There's no question in my mind that as time goes on through some of the technologies we've been hearing about, those are going to be genetic epilepsies. So in my view, what we consider the common epilepsies are in fact going to be subsets of the rare epilepsies, which makes it even bigger. Going back, which says make a difference, that blue arrow, which says learning healthcare systems, that's now on the Rare Epilepsy Network. The learning healthcare system in epilepsy is something out of the Anderson Center at Children's Hospital in Cincinnati. It's the center of network-based quality improvement. And our mission in the Epilepsy Learning Health System is to improve quality of life, improve seizure control, and improve seizure freedom. Oh, and right down at the bottom, co-production means that families, patients, and healthcare professionals all work together as equal partners. The question is, how do you do it? And one of the things that we do via the Anderson Center that essentially creates the registry is we put diagnoses in the electronic health record so that in our epilepsy note, we list genetic etiologies so they don't get lost and they're encoded. So that's how we get them into the registry. But then what happens next? You've got this stuff in the registry. What do you do with it? It's been a one-way process of getting data into something. How do you make it actionable? And briefly, I want to give homage to Dr. Steve Downs, who I think may be here or will soon be here, because at the University of Indiana, he's created something called Chica, bringing knowledge via computer automation. This is a slide that Steve gave me, which just demonstrates that doctors aren't perfectible, meaning try as we may, we're still not going to get it perfectly. Let's use technology to help. And the numbers you see here is how far we fall behind in meeting guidelines. The Child Neurology Foundation, funded by Greenwich Biosciences, created a project to incorporate knowledge about sudden unexpected death in epilepsy into the note. Children and adults are lost every year due to epilepsy, and no one's ever talked to them about it. How is the doctor supposed to know that someone should be talked about by SUDEP? It's a guideline, it's a quality measure, but how do you get it out there? And what Dr. Downs and his Digital Health Solutions group has done is created clinical decision support. And better yet, it's in a primary care setting, so the specialist doesn't even see it yet. And what this does is using codes in the record, identifies who has epilepsy through patient-reported outcomes, says who has epilepsy out of control. It brings up an alert that says, doctor or nurse, you need to talk to this person about SUDEP, and here are the materials that we're going to give you to give them. So you go from the quality measure to the identification to the action. And I look at this as the future of a lot of medicine. So in summary, we started talking about guidelines which are necessary to bring knowledge together and make recommendations. We then talked about quality measures as a means of quantifying how someone is doing and making it accountable to the world. And finally, using clinical decision support to take that knowledge and bring it to the office in a usable fashion. With that, I thank you.
So I think we're going to save questions for the end, and I'm going to move on to the next session. So when they asked me to speak about standards of care, I knew that Jeffrey was going to talk about developing standards of care, and I'm going to talk a little bit about that as well. But the other thing that I thought was extremely important is how do we implement and then evaluate those standards of care? Because as Jeffrey just said, we can develop all the standards of care that we want, but that doesn't mean that anyone's going to implement them and use them, which is of no avail to the community. So just a little bit about Duchenne Muscular Dystrophy. I'm Kathi Kinnett. I work with Parent Project Muscular Dystrophy. We're a fierce group of about 22 people who are insanely driven to do way too much. So we actually accomplish a lot of things, which is amazing. But if you don't know Duchenne, Duchenne is an X-linked neuromuscular disorder with boys, mostly all boys are born with it with an early onset of symptoms early in childhood. The rate is about, the incidence rate is about 1 in 5,364 boys. The spontaneous mutation rate is about 30%, so we have about 30% of our patients that are born without any family history whatsoever and no inkling on the parents' part that this is even a possibility. Diagnosis, because of every other rare disease, like every other rare disease in the world, those signs are somewhat ambiguous, and boys will be boys, and everybody develops at a different level, is unfortunately at about 3 to 5 years of age. We're trying to decrease that, and we're working fervently on newborn diagnosis and screening tools that are now available in the population to try to help primary care evaluate and diagnose much earlier. There's a predictable course of this diagnosis, progressive loss of pump function, and it's 100% lethal with an average lifespan of about 28 years old currently. So what happens in dystrophin, or Duchenne, there's a lack of dystrophin. Dystrophin is a protein that's in every single muscle fiber of your body. It links the intracellular matrix with the extracellular matrix and protects the muscle membrane. And when that is gone, it creates tiny microfissures in the cell membrane that allow calcium to come in. Calcium is toxic to the muscle and destroys it, and then the muscle is replaced by fat and fibrous tissue. So if you look at this young man's calves, which are usually the first sign of Duchenne, they are very big and they look like they're very muscular, but actually they're replaced by fat and fibrous tissue. It's not muscle at all. And this unfortunately happens in all muscles of the body, making this an extremely complex diagnosis. There are muscles in every part of your body, so every muscle is infected or impacted by Duchenne. And so the impact of the body and that system, that diagnosis, impacts every system of the body, necessitating a comprehensive team of providers to care for every part of the body. This has become more of an adult diagnosis, so we need care across the lifespan. So just a bit about PPMD. Again, we have four arms: research, advocacy, care, and education. We're extremely busy on the Hill and extremely busy in all areas. And one thing that one of the first things that we accomplished was to get the MD Care Act signed into law in 2001. There are many parts of the MD Care Act, but one of the primary parts of the MD Care Act was affording a portion of the funds to the Center for Disease Control to establish guidelines for Duchenne care. And those guidelines focused on 8 areas of care, and they were, like, just as Jeffrey said, we didn't have a lot of evidence. There's a lot of rare diseases, and when you go to the literature to look for evidence to base standards of care on, if there's not been a lot of research that's been done in those areas, there isn't evidence available. And so the initial guidelines were largely based on expert opinion to try to standardize care across the neuromuscular specialists across the country. They were published in 3 volumes of Lancet in 2010 and have been recently updated. So the original care guidelines focused on 8 subspecialty areas of care: diagnosis, neuromuscular management, rehab management, GI, nutrition, respiratory, cardiac, ortho, psychosocial. And at that point in 2010, when they were originally published, this was a pediatric diagnosis. Largely because of advances in care and the establishment of standards of care, we've been able to push that, the lifespan of Duchenne by about 10 years, so that now this has become an adult diagnosis as well. So the updated guidelines, just published recently in January of 2018, have updated each of those areas of care to include not only pediatric but adult guidelines as well, and include 3 additional guidelines that include primary and emergency care. So how do you manage patients on a primary care level, and then what happens when you go to the emergency room? Endocrine management, because steroids are the gold standard of care, starting extremely early and generally given daily. Chronic daily steroid management leads to a host of problems, including pubertal delay, growth delay, and osteoporosis. So endocrine management was becoming increasingly important. And transition care. Now we have adults. We have to transition them from pediatric to adult care. And how do we transition them in terms of medical model and then in terms of an emotional, psychosocial model as well? Unfortunately, in both of these editions, primarily in the 2010 edition, there was no methodology around evaluating the implementation or the impact of these guidelines on quality or quantity of life. And that's kind of where we stepped in. So in 2012, 2 years after these guidelines were established, we looked around and decided that nobody was following these guidelines, and that people were complaining that care was all over the place, and that we needed to really pull people together and to decide how we were going to implement these care guidelines. There needed to be a carrot, because we can't, obviously you can't tell people what to do. People don't really want to be told what to do, but we had to give them a reason to do what they wanted to do in terms of best practices and what was best for families across the country. We invited about 17 different institutions. They were all required to bring somebody from the top floor in a suit with them, because it doesn't matter if you want to provide great care if your administration says we don't have the time or the money or the resources for that. As a result of this meeting, we identified 4 themes. There were discrepancies in care across the country, largely due to discrepancies in perception of what those care guidelines were in practice. How were they going to use those care guidelines? There were discrepancies in models of care. So if there was a cardiac guideline that said that you needed to see every patient once a year and that they needed to get regular echoes, what were regular echoes, right? So an regular echo could be every 6 months, regular could be every 3 years. It depended on how that person was interpreting those guidelines. And who was interpreting that echo? So in terms of the model of care, was the neurologist ordering the echo and then looking at the report and saying, oh yeah, it's fine? Or was the cardiologist actually looking at the echo? So there were many discrepancies in models of clinical care. Again, there were discrepancies in the implementation of care, and this was impacting both clinical care and clinical trials. So many of the sites across the country are major sites for clinical trials, and many of them use functional measures such as the 6-minute walk test as an outcome measure. So if you have one center that's aggressively promoting stretching and wearing braces at night and physical therapy, and another one that says, just do it whenever you want, how do you compare the clinic or the trial outcomes from both of those centers? They seem to be discrepant to me. So we decided to use those 4 themes and build upon them a program of certification. So we developed the Certified Duchenne Care Center program. And the goal of this program was to provide care and organize a network across the country and hopefully globally at some point that will provide care in alignment with the standards of the Certified Duchenne Care Center program, which were developed in alignment with the CDC care considerations. And the group decided to do 4 things. So first of all, who's on your team? So to identify who really needed to be involved in comprehensive Duchenne care. And I would say that every rare disease can do this. So sit down and say, these are the systems that are involved in the care for our rare disease, for my child, and this is who needs to be on the team. Once we evaluated or decided who needed to be on the team, we organized experts in that subspecialty area and tasked them with developing elements of care by which we could evaluate the care in that subspecialty. So for example, in cardiology, that's my background, obviously, it's easier for me to talk about it. So in cardiology, how often should they be seen? When should they get an EKG? When should they get an echo? Who should get a cardiac MRI? When should they start medications? So give me at least 5 to 10 variables that I can use to evaluate that subspecialty area of care. And then based on the survey that tells me who's on the team and what care the team members are providing, we developed the Certified Duchenne Care Center program and then certified centers around the country that were capable of providing that level of care. So this is a closed loop process that we developed in order to integrate every stakeholder in the Duchenne community. So first of all, The center sends us an application and says we want to apply for certification. We send them back a list of people that they have to have on their Certified Duchenne Care Center team, comprehensive care team. They'd send us back a note that says, yes, we've got all those people, no problem. We then open up an application and require each subspecialist to identify the elements of care that they're providing to their patients. There's an opportunity for them to offer comments and text, and we go back and forth until we're extremely comfortable that they're providing care in the way, in agreement with the care guidelines and in a way that, that our community is happy with. Once we get those 2 applications completed, we do a site visit, which usually includes always includes 2 members of the certification committee. The object of that 2-day site visit is to interview as many people on the team as possible in order to validate the information that we found in the survey. Sometimes we find that it gets validated, and sometimes we find that it doesn't. And so that site visit, while it's cumbersome and time-consuming, has become an extremely valuable part of the certification process, and one where we've learned that it's great for sites to be able to show off, and it's great for us to be able to visit many sites. We can give them suggestions as to things that we've seen at the other 30 centers that we've seen across the country that may enhance the care and services that they're capable of providing to their patients. And then if we see anything that isn't quite in line with the certification process, we discuss that with them, and that's a requirement that needs to be met first before certification can be granted. The second day of the visit is to attend clinic. So each of the people on the certification committee join with a patient family and go through that visit with them. And the purpose of that is to evaluate what the flow is in that comprehensive clinic, to see what the communication is between the members, and to talk with the family and the child about their experiences at that center. And again, it's generally a time for that center to show off. Once we gather all that information, we organize it and present it in a summary to the greater certification committee, and they review that summary and then evaluate whether they are appropriate for certification or if they need to work on some things. Nobody leaves a site visit without all of these things being discussed. So nobody that applies for certification gets a summary that is full of surprises and they have no idea that they needed to do before we would certify them. So everybody's fully aware and on the same page before we leave the visit of what needs to be done prior to certification. Once that summary is reviewed by the certification committee, the evaluation is given back to the center with suggestions or a recommendation for certification. And if they're recommended to be for certification, they're certified for 5 years. Each year, we send a report back to the centers and ask that they tell us how many patients they're seeing, as well as any changes in their staff and faculty, as well as how they're addressing the suggestions and the requirements that they had met and are probably enhancing since our time with them at the site visit. In addition, at 6 months, we asked them for changes in their staff and faculty and updates on their patient numbers. And then once a year, they address the certification summary. We do keep in regular contact with these centers. We do keep in regular contact with patients. And the third part of our certification program is called a clinical experiences summary. And each certified center is encouraged to have patients complete the clinical experiences summary that lets us know how families perceive the care and services that they receive at that center. They're all anonymous, so they can say anything they want, which is great. And then we aggregate all those responses and give them back to the center. The center then uses those responses for continuous quality improvement. So not only do we have the center's view of how they're providing care and services, we have a boots on the ground view of what they're doing. Oh, I forgot to, and the other thing that we do in the site visit is evaluate charts. So there's 6 to 8 chart evaluations that we do to make sure that, to validate what's in the summary and to validate what we've heard in the interviews. So they apply, we do the site visit with interviews, chart reviews, and the clinic visit, and then collect patient or clinical experiences summary from each centers, and then feed those back to the center. So it's a continuous closed loop process that we've found to be extremely beneficial. So this is our current map. This is what we've done, and I can't believe we've done this since 2014, which has been quite an undertaking, but we're very proud of this. Again, the goal was to reduce discrepancies in care, and I'm very proud to say that the care provided at all 20 of our certified Duchenne care centers is harmonized and in agreement with the care guidelines. We have made comprehensive care and services much more available to people living with Duchenne's. As you can see on the map, there are holes in our map, which we're well aware of, but we do have affiliate centers that we work with in some of those areas and are able to refer patients to those places, and then those places are able to then reach out to other certified Duchenne care centers that are in their area for expertise and assistance when needed. We've also met our goal to strengthen clinical trial outcomes by standardizing the care at most of these centers, or all of these centers, most of which are major clinical trial sites. So we're not finished. We're never finished, are we? None of us in this space are ever finished. One of the things that we're extremely proud of is this morning, Stephen spoke about the need for an ICD code. It's really hard to evaluate the impact of care and services if your diagnosis doesn't have an ICD code. And who would have thought that Duchenne and Becker didn't have an ICD code, but we didn't. So as of October 1st, just this week, it's been added to the ICD-10, as well as a few other codes. So if you don't have an ICD code, or if you're not sure if you've got an ICD code, I would encourage you to go look for that and then present your case to the World Health Organization about why this is necessary. Because if you can't find these people, you can't evaluate quality or quantity of life. With the ICD code, we've been able to develop metrics that are easily accessed by running an EHR report that will let us know about the services that people in our certified centers are receiving. So we've identified 13 metrics. We're going to start to run those from October to December, and then December evaluate how well we were able to run reports on whether or not our patients at those centers were able to obtain these services. We know it won't be perfect because many patients don't get those services at the places where they're seen for care, but we think that it's a good start. And then with the ICD code, the metrics will help to evaluate the continued implementation of the guidelines across the certified centers. So we're hoping as more people become linked to this ICD code, we'll be able to then pull the ICD codes and evaluate the care that people are receiving, as well as the impact of that care on quality and quantity of life. So we'll be able to follow clinically reported outcomes longitudinally. We can collect clinically reported outcomes within the Duchenne registry. So this is a registry that we've had for about 4 years that includes over 10 years, that includes over 4,000 patients. And we've just announced an enhancement to that registry, so we'll be able to collect a lot more data. And then as we start to evaluate the impact of these care guidelines on quality and quantity of life, we'll be able to go back to those subspecialty areas and evaluate whether this made a difference. Maybe it's made huge impact. Maybe it's really made no difference at all. But until we can start to collect that data, we really can't evaluate any of these things. So that's all I have to say as well. Oh, I went really quick. I could talk about any of these slides for about an hour, and I'm happy to take a deeper dive into any of them whenever anybody has a lot of time. But we're happy at this time to entertain questions if you have questions.
So right now, as Kathi said, we are going to make the switch. We will answer questions by bringing around a microphone and then also taking any questions that have been submitted online. So I saw a hand over here.
I must say that that's an amazing process that you've put together from the top down.
Thanks.
Well done. Is that process published somewhere?
Yes. Thank you. I did want to say that. It is published somewhere. And it's in PLA's Currents Muscular Dystrophy, and it's searchable on Medline. And it's also available on the PPMD website. My contact information is Kathi, Kathi, @parentprojectmd.org. So if you can't find it for any reason, let me know, and I'm happy to share it. But the process is published. Thank you for asking that.
That's fantastic. And then I had one other comment on the guidelines in the cholesterol space. It seems as though with the requirement of level 1 data, that we don't ever have anything put in the guidelines until we have something to fix it with.
So that's a very good point. As it turns out, there does not necessarily, again, across the guidelines that I know about, have to be level 1. And a number of guidelines, of course, have level 1 data, but we've seen recommendations based on level 2 and even level 3, depending on the potential impact.
Well, when you're talking about outcome data, typically outcome data comes out of a level 1 study, and to be able to look at the return on investment of various different areas, it tends to go back and defer to outcome data, which only comes from a randomized controlled clinical trial. So we've talked about outcomes data, and I want to, and this, I'm actually, thanks for asking, bringing that to our attention. There's different kinds of outcomes that we've heard about. We've heard about outcomes from RCTs, and that's we talk about level 1. There's also a wealth of data from quality improvement literature. And that data is getting more and more attention because it looks at clinical outcomes which are not necessarily obtained from RCTs. The other big issue, and you saw it on Kathy's slides, when looking at things to do, there are process outcomes. So for example, in my world, documentation of seizure frequency in the EHR. That's a process outcome. How often is it being done? That's different than a clinical outcome of reducing seizures. And so for many, many things, what we focus on are the process outcomes, because that's what we can improve until we get the RCTs to get the clinical outcomes. Well, we've known about lipoprotein delay since 1964, but unfortunately there was no diagnosis code, which actually we just got.
Good. Congratulations.
So now in the electronic health record, we can actually start to gather data, but we lost decades.
Yeah. So just one of my hobbies is coding. And so ICD-10, which the United States adopted in 2015, was adopted in the rest of the world in about 1994. ICD was designed for epidemiology, to keep track initially of mortality, and it was only in the 1960s when it got to morbidity, the names of disorders. It's not really built to follow disease progression. That's not what it does. So 2 points. One is that ICD-11, which is in beta testing now, will not be in the States until I'm not in the States, meaning a long, long time from now, because that's just the way the government runs. However, the CMS, Center for Medicare and Medicaid Services, meets twice a year, Coordination and Maintenance Committee, where new codes can be suggested. And so although ICD-11 will answer a lot of this, ICD-10 can be modified to track things. There's another coding system that sits behind ICD called Snomed, Systemic Nomenclature of Medical Diseases. And that was been around for a long time. Snomed, which actually is embedded in many electronic health records, has codes to follow outcomes and processes that are not in ICD. And so there is a system that's available right now to accomplish a lot of our aims, but it's such a wonkish thing that people don't know about it or don't use it. You Snomed International, that's the browser, that's the URL, and then you'll see a bunch of flags because Snomed is an international classification. Each country has its own Snomed chapters, and you click on the country that you're from, the States, and it brings up the codes. It has a nice search engine, and you can see what's available.
So you have to browse through to figure out which code is applicable to your disease state, or is there some kind of index somewhere?
There is an index. As it turns out, it's a lot faster just to type in search cholesterol, and it brings up all the families of codes and tells you where to go.
Thank you.
One of the barriers to trying to collect clinical trial or clinical outcomes and patient outcomes is time and money. And so if you're starting to do this, you might want to evaluate the easiest things to pull from your medical record for your disease state. So for example, I can't tell you right now whether we've impacted the length of life in Duchenne because we're studying cardiac meds at age 10. I can't tell you that. But I can tell you whether or not you've seen a cardiologist, how many people have seen a cardiologist once a year. I can tell how many people have had an echo once a year. I can tell how many people have had a cardiac MRI once a year. And then eventually, by looking at those care parameters, we'll be able to look at impact later on. So those are, care and services to me are two different things. So services are who you saw and what they did to you, and care is actually whether there's an impact on your quality and quantity of life. So you really need to become familiar with your electronic health record and what the codes are, what the specific parameters are that you want to evaluate for your disease process and what's easiest. People will run it if it's quick and easy.
How do you get access to the electronic health records?
Well, as a patient, you should have access to your health record through a patient portal. Depending on your institution, they're all different. When the government said, let's have an electronic medical record, that was a great idea. But now we have variability in that as well, so you have to become familiar with what you have.
But as an organization, as a foundation, if we wanted to put some kind of metrics behind what was going on for our patient group,
you may need patient-reported outcomes at this point. You may need to ask your patients in a registry how many times you've seen the subspecialist that you need to see and what the result was.
Can we take the next question now?
You talked a lot about the creation of the guidelines and the rigor that it takes. In the case of a rare syndrome, we have, let's say, 70 children around the world who see 70 different doctors. And every one time we go to see one of these doctors, they say, you know more about this than we do. So how do the parents work? What's the next step for the parents to create the guidelines? Or who do we work with so that we can, when a new patient is discovered, they don't have to hear that we don't know anything?
Yeah. So part of my personal motivation comes from a parent that I work with who's also a scientist, and her daughter has a rare epilepsy, and her question is really exactly what yours. How do we get attention? How do we get people to know about it? And how do we bring knowledge forth so that other parents don't have to do this over and over again and get variable answers? So I think there's a couple of approaches. One is, do not underestimate the power of parents and caregivers and advocacy organizations, because over and over again, that's what makes things happen. I mean, we all have different roles. I'm a pretty good neurologist. I don't do advocacy that well, but there are a lot of people that do. So I think the first thing is link up with your organization. That's the first thing. The second thing is partnerships. Partnerships with involved doctors and nurses to bring in another kind of expertise. And then when you have something, 70 people in the world, the reality is you're not going to get a $50,000 investment by a big organization to create a guideline, because there are other folks, ahead on the line who have more people involved. So that's just a financial reality. However, via organizations like the Rare Epilepsy Network that bring together folks, they're a very good means. The reason that the Epilepsy Learning Health System, the way that came about was because the Epilepsy Foundation partners with the Rare Epilepsy Network, a patient-powered network. There were funds available via PCORI, Patient-Centered Outcome Research Institute, to create networks. And that's how the Epilepsy Network came into existence, via the Anderson Center. And so it's not the best answer to what you want and I want, but if there's a rare disorder, we can put it into the electronic note and you can find it. And as we've heard, ascertainment is where it all starts. Because if you can't find folks, you can't assess a whole bunch of stuff. So I think that would be my counsel.
So just in the interest of time, we're going to take one more question in the room and then answer one question from the app. Is there anyone in particular? Anyone on this side? Question? I think over in this corner.
Nope.
Sorry, bit of a walk over here.
So you talked a bit about guidelines and specifically physician autonomy of care. What have you found to be the best way of publication of those guidelines? Specifically, I work with emergency medicine. I've seen physicians use Epic best practices, third-party systems like UpToDate. They search the NIH website for their most recent publications. And I've even seen physicians use Wikipedia for things that aren't as common and don't have a lot of background within them. So when you make these best practices, what's the best way for you to publish them and get the physicians to actually use them in practice?
So the reason I emphasized the American Academy of Neurology is that's our big organization. That has the most gravitas. That's the organization that has the most weight on the hill in affecting change. And more and more neurologists use the Academy guidelines as standard of practice. So whatever the equivalent is in the world of emergency medicine, I think would be the way to go.
And I've found the best way to educate emergency medicine staff and faculty is with parents. So what we've done is create an emergency card as well as a mobile app that has all of the emergency information on it so the parents have it at their fingertips. Because as you know, ER docs and nurses are so transient, there's no way we could get everybody who's an ER doc in a room and get them to focus on emergent Duchenne care. But when they see a patient, if a parent says, these are the guidelines that go with my specific diagnosis and give them to the person, generally they'll pay attention. In addition, we've given parents access to their certified centers. So they're encouraged to call their neuromuscular doc or whoever that subspecialist is that they need, not leave that to the ER staff, which has been wholly unfruitful, and then have that person get in touch with the emergency staff at that time. So the onus, sadly, at this point for emergency care has been on the parents and the patients, but that's been the most effective for us.
Thank you. So we have one question online. Reads, as a patient, parent, education organization, how do we drive the implementation of standards or guidelines of care? We find that many parents inherently trust their doctors. How do we create more informed consumers of healthcare?
I'll start. So 3 volumes of Lancet, who wants to read that? So what we did was to create a family guide. So it's a much shorter, much abbreviated version of those 3 volumes so that parents could refer to that information. We also created a one-pager, which is called the Imperatives of Duchenne MD, so that parents and patients can look at those standards. It's a one-page snapshot of what every person living with Duchenne needs every year. So by empowering, by increasing the amount of knowledge, providing resources to parents, we've empowered them to then go to their providers and say, no, this is what it says right here, and here's the professional resource if you need to look at it, but I know that this is what my child needs, and I need you to provide it, or I'm going to need to go someplace else where I can get it. Patients will vote with their feet. If they don't like what they're getting and they have knowledge that that's what they need, they will go where they get it, and institutions don't like that. So it's important that institutions have started to pay attention to what those guidelines are and to provide care in agreement with the guidelines that are published.
Thank you. Thank you both so much for speaking today. Before we conclude this session, if everybody would please log on and submit a survey on the app of how this session went. Let's give a big round of applause to Jeffrey and Kathi. Thank you, everybody, for coming. Lunch is now out there. I'm sure everybody's eager to get there.